Welcome to Mic'd Up with Chiro Up. Brandon Steele here today, and I am going to be your tour guide. And a fair warning, this episode does not stay in one lane, which means only one thing. Tim is not here to keep me on track. This is usually where he gets kind of nervous, thinking to himself, what is Brandon going to cover? What's going to be on the outline? However, this is probably one of the best thought out podcasts that I've done for a reason. This is something that actually built my practice. And it's something that when I was in Logan, I worked on extensively and really helped me learn how to do professional marketing. Before we jump into today's episode, I've got something pretty exciting to share. Right now, with Mic'd Up with Chiro Up is sitting right at 70 written reviews, and we're on a mission to hit 100. So here's what we're doing. We're launching our 100 review campaign giveaway between now and March 25th. If you leave a written review on Apple Podcasts or Spotify, you're automatically entered to win. So if Mic'd Up with Chiro Up has helped you, has challenged you, has inspired you, take 60 seconds, leave a written review, and you just might hear your name on a future episode. Let's get to 100 together. So today we're going to dive into a single story that's going to tie together jaw pain, smart professional marketing, and real business reports and action steps that you can take in your practice to stay profitable, to stay focused, and the most important part, stay out of the red. Today's format's going to be a little bit different. I'm going to blend some of the clinical, some of the strategic things that we do at Chiro Up with my private practice at Premier Rehab. And I'm going to try to keep it in a continuous narrative. This is a little bit different than what we normally do, but that's really how practice ownership works. So let's get into this. So when I first became a preceptor, out of Logan College of Chiropractic, I still actually live in the same place that I did when I was in school 20 years ago. I worked closely with an oral surgeon and became the primary provider for his patients with jaw pain. Most of them carried a diagnosis of TMD, but what became really clear in my first couple of weeks is that really none of their pain was structural. He sent nearly all these patients to me. He kept maybe 3% to 5% where really something had to be done, structural or arthrocentesis or even surgery, but the rest came into my treatment room. This really resulted in or was because of muscle imbalance. And I think that what we saw was 95% there was a myogenous driver to this dysfunction. And really, when you fall into the research, it's about the same. It's 85 to 80% myogenous when you look at the research. And myogenous dysfunction could be a trigger from trauma or a dental procedure or poor mechanics or posture. These are all things that can result in muscle dysfunction around a jaw, as we know about every other place in the body. However, here's the cool piece about this when it comes to TMD is that manual therapy, postural reeducation, joint mobilization, manipulation, and targeted rehabilitation, just as we do for every other condition, works really well. Now, in this case, or at least in my experience, I still had pharmacological care. We still had a flat plane splint that was added to these patients. So some things that maybe we don't do in practice. However, we got really impressive results, meaning patients improved, mouth opening increased, and symptoms resolved quickly. Not months. Patients had these for a very long time, but we were able to solve it fast. And really that experience pushed me to take this work a touch further. I did some research my final year at Logan on the effect of mandibular opening, and it still shapes how I practice today. So in this episode, I want to walk you through that story, what worked, what I still do clinically, and how some of these same principles extend beyond patient care and drive into my professional marketing today, and really has a big impact on my practice growth. So, problem solving and getting people out of pain is half the equation. Knowing how to communicate that value with your patients and the provider that's referring to you does build a modern, sustainable chiropractic practice. Now, TMD highlights one of the greatest assets that we have as a healthcare provider, in that as a chiropractor, we are trained to recognize patterns. These are some of the most easy things to recognize in some people, but also in the case of TMD, one of the most challenging puzzles to solve, because these patients have this problem for so long and they usually don't fit into just one mold. And I'm going to explain that in a second, but pattern recognition is very, very important. I think I see this in every aspect. It doesn't mean that the best athlete, the best business minds, they see patterns while others see chaos. If you look at a baseball hitter, he or she can read a curveball from just the body language of a pitcher in a fraction of a second, just as we do. An elite chiropractor does the same. He can recognize patterns of symptoms and signs and patient presentation to gain a little bit of clarity and confidence in a diagnosis. However, jaw pain, TMD, lives in a touch of a gray area. They don't follow the chapter of a book all the time. There's overlapping symptoms like vertigo and neck pain and overwhelming stress and persistent other complaints that don't fully resolve with traditional approaches. This is that patient that walks in your office with your intake form and the entire body picker is highlighted. Or if you use paper still, the whole body is circled and you're like, oh, geez, this is going to be a tough one. But today's podcast uses jaw pain as let's call it a clinical example, how by expanding your assessment toolbox can, one, increase your confidence, your clarity, your outcomes in practice, but two, probably the more important one, is to expand the amount and types of patients that fit into your practice. I've had the same kind of conversation about vertigo, is that, if you're seeing patients with vertigo, the question is, are you evaluating and are you treating it? You're going to see the same thing with TMD. And today I'm going to walk you through a couple simple orthopedic tests that you can apply right away. I'm going to connect those to some practical evidence-based treatment strategies that are already in ChiroUp. So you're going to be able to manage these cases in your office quickly, fast, increase patient compliance and satisfaction. And then as we wrap up with this podcast, I'm going to cover two things that every chiropractor cares about. And I think that's the thing that kind of creates a little bit of a unique value add to ChiroUp, is how can we actually communicate these things and communicate these complex findings to patients simply? One, we can get into our documentation and billing for us, for our practice. However, how can we relay the most important things to our patients to help them also help us get them out of pain? This podcast kind of started, or the idea behind this podcast started 2 weeks ago. And I had a patient walk into my office and says, I think I have TMJ. And if you know my personality, I responded with this. I said, congratulations, you have 2 TMJs. And they looked at me a little bit weird, and I don't know if I would recommend that response. But as well as I do, is that TMJ is simply the name of the joint. TMD is the disorder. However, if they say they have TMJ, they talk to their parents, they talk to Google, and they realize what they have. But also, they're getting a different filter of what that diagnosis is based on who they heard the term from. But when you think about it, and they do have 2 TMJs, it's rarely a simple or singular problem. I mean, think about that you have a joint that has 2 connections. So if you have a problem with one, there's actually a problem with both. And this is a floating bone attached to your skull. So more precisely, and there won't be a spelling test on this, it is a ganglionoarthrodial joint, but really I call it a gangliomodiarthrodial since it does connect to the skull at 2 places. And this one term, while I don't know how to spell it, this one term, though, is the basis behind the rehab. So a gangliomus joint is a hinge joint. And that's important. So remember this, because that kind of joint really only does rotation. So the first 50% of mouth opening. The arthrodial part of that word is the gliding piece. This is why you need anterior translation during the second 50% of opening. And I'm going to bring up that term later on in the podcast, but understanding the first 50% of opening, meaning the first single cheeseburger that you open, is pure hinge motion. And then if you went to Five Guys Burgers and Fries and you went for the double cheeseburger, you need to actually go through a second range of motion with this anterior translation to get that mouth a touch wider. So how did this patient end up in my office? Well, in short, failed care. Which is what we see normally. I'd love to if every patient came in to see me first, but for the longer version, they went to massage therapy. They had the wait and see methodology of let's see if this goes away by itself, which unfortunately did not work for them. They went through dental care. They also had a football mouth guard that they molded from Walmart to help create a little bit of distance between the teeth. And unfortunately, those things in combination did not help. So the patient actually arrived with a self-diagnosis based on the internet and conversation with friends. So the first thing that I need to do with this patient is to identify the problem. And when I say identify the problem, that's not necessarily the tissue source, and we will do that. But to identify, is this patient supposed to be in my office? Someone with a broken femur, probably not going to be best served in my office, but someone with muscle dysfunction, tendon problems, joint issues, neurologic issues, yeah, I want to see those patients. When it comes to TMD, though, my first question in my brain is this muscle or is this joint? And when I say muscle, I really mean all the soft tissue, the ligaments, the tendons all around that area, including the disc, or is it within the joint? When it's within the joint, this actually changes what we can do with the patient, the diagnosis, and really the prognosis. Now, remember this, but before we kind of dive into the first orthopedic test, or the most important orthopedic test to identify this, keep in mind the TMJ is formed by two bones. You have the mandibular condyle, which is going to be the jaw, and then you have the temporal bone, which is the superior margin of that, and that is the mandibular fossa. I think it's also called the glenoid fossa, depending on which picture you're looking at on the internet. And in between there is a disc. Now, this is by far the funniest thing that I think about in my brain. And obviously, we all have things that we think about in our brain, but here's a little food for thought. Have you ever had a patient walk in your office and say they have a slipped disc? Like in the back of your brain, you're like, that disc didn't go anywhere. We don't have slipped disc. Yeah, we have disc bulges and herniation, those things, but nothing gets slipped. Well, here's the funny part. In the TMJ, you can have slippage of a disc. So that's kind of the funny things that I think about. And that's what you'd get when you get the popping, cracking, clicking, jaw locking, is actually the disc within the TMJ can fall off that mandibular condyle and cause those noise. Well, back on track. So this articular disc that I'm talking about is largely not pain sensitive. However, the retrodiscal tissues, the capsule, the synovium, the ligaments, all the things that make up the outside or borders of that joint really are. So there is a test that we can do to determine that joint health. Now, I call it the centric relation provocation test. I've heard other terms describe that. However, it's really, can we compress that joint? And does it reproduce familiar pain? And if it does, it tells us we have a joint pain source. That's arthralgia, that's capsulitis, synovitis, degenerative change of the disc, sensitized retrodiscal tissue. This kind of stuff, when we do this, it tells us it is within the joint. Now, remember this. The purpose of orthopedic testing is to push on it, it's to pull on it, it's to make it work, whatever that tissue or orthopedic test is. So we're really looking for what tissue is giving way or what tissue is reproducing the patient's symptoms. It doesn't always mean that we've identified the root cause of the entire problem, but does show us the weakest link in the system. Now, why is this important? It's important because the patient sitting in your office complaining about this weakest link, we need to choose the right test to help the patient know that we know what's going on. Yes, it helps us narrow the diagnosis, but it does a very important piece over and above the information you gained. It really tells the patient that you took a controlled, intentional way to affirm the patient has a problem. Because the worst case scenario is you do all your orthopedic tests and you never reproduce a pain. The patient and you are a touch confused. However, when you can reproduce the pain and you can identify it and say, hey, is that your pain? It tells the patient you know what's going on, and then you can have a clear plan to address it and really get buy-in moving forward that you found what that patient is talking about. And this CRPT test is exactly that. This is a very consistent test. It is also a test that is reproducible to identify the pain generator, and in this case, it being the actual joint. Now, how do you do this test? Of course, you can go into Chiropractors and look up the CRPT test. However, this is a test when the patient is supine, they're nice and relaxed, everything is going good. What you're going to do is put two fingers, your fourth and fifth fingers, behind the jaw closest to the ear, where it's going directly down towards their body. And then the other two fingers, your second and third finger, on the distal part of the mandible. And what you're going to do is you're going to gently load the jaw, and you're looking for reproduction of that pain, and really looking for, is that reproducing the reason they came in. What you can do is you can incrementally change the degree of mouth opening while you're loading it, and what you're looking for is, with that superior compressive pressure, does that reproduce that pain? And I think this is one of those things that when you do reproduce that, you get that psychological aspect, but also it's telling you, where the problem is. When you do this, you're normally going to get reproduction on the same side that they're having their problem. And this can help identify, is it truly a muscle problem or a joint problem? If it's a muscle problem, the superior lateral pterygoid, if it's a muscle problem with the temporalis or masseter, you're not compressing, you're not stretching, and you're also not making that muscle work. So it's not going to reproduce pain. But if it does, once again, we're looking at more of a TMJ arthralgia, capsulitis, synovitis, or any kind of DJD. So what are the three things this test tells us? If it is positive, treatment's going to take a little bit longer, and that stinks for you and the patient, but it is what it is, because that tissue takes longer to heal. It also means that I'm not going to be aggressively stretching the capsule or joint past pain. I need to let this tissue calm down. And third, this is a case that often does benefit from a referral, if you feel comfortable with it, to back to their dentist, to their oral surgeon, or their medical provider, because we need to do things for degenerative change within the joint as compared to just typical stretching things, the things that we do on a regular basis. Now, I'm going to bring this up with a little bit of a caveat. This test is reliable. And that's important, because a lot of things, when you look at the research that we do as chiropractors, is not intra-rater reliable, meaning motion palpation, as I do every single day on every single patient, is not intra-tester reliable. However, this is one that, when done properly, so please take a look at the video in Chirop, is very, very reliable. And I'll include some studies in the show notes. I think it was a Vischer study that talked about this. Now, one thing about this test that I do want to make clear, though, is that the pain provocation test is for joint pain, not a disc displacement detector, like we talked about the slip disc. So we're going to help differentiate between myogenic and arthrogenic, but when it comes to all the issues that could happen within the joint, it can't differentiate between those. It just says, is this due to the muscle or is this due to the joint? Now, the good news is that most TMD patients, their jaw pain is usually the result of overworked muscles secondary to joint dysfunction, not degeneration. So their CRPT test is going to be negative. And since that test is going to be negative, they are going to respond extremely well to the conservative care, especially manual therapy and targeted rehabilitation that you and I provide. Because when we understand what's driving the symptoms, the clinical path becomes much clearer and far less invasive, both in procedure and medication, two things that I do not want for my patients. So in a moment, I'm going to take you through the two manual therapy techniques and one rehabilitation exercise that the research considers essential to manage these cases. But before we get on the hands-on care, I want to talk about one thing within this. As a part of this narrative, this piece is really how I built my practice, not necessarily how you have to build your practice, but if you're looking to get better referral management, I guess I'll call it that. Some people call it MD marketing, dental marketing, marketing to CrossFit gyms, whatever it may be. In this case, what built my practice at the very beginning was dental marketing, dentist marketing. And I still do it today. And I think this is one of the most, I'll say, important clinical reports that you're going to run in practice, and of all the referrals you had, because what are you doing with those referrals? And when it comes to a dentist or a medical doctor sending someone to my patient, I need to send something back. Not the patient, hopefully, but I want to send an initial report, reevaluation reports, and release reports to these patients. So if you go into one of the reporting systems in the Chiro EHR for scheduling, if you filter out all the patients I saw in the last week for new patients and new injuries, with that report, I make sure that initial report is sent out to each one of those people within that week. Now, in the case of a dental problem, I'm not going to send it to their initial report back to the medical doctor. I'll send it to the dentist. So the key to this entire process is having every healthcare provider that you in your area already built in your database. If you have this in Chiro, the letters are generated automatically. You can send them in seconds, not minutes, not hours. You don't need some kind of other high-tech system to get you 40 new patients every month, which you know doesn't happen with all the Facebook ads you see. This system alone has been the biggest driver of my practice. Now, if you're thinking in terms of marketing ROI, the time, not the money, the time invested in creating and maintaining this referral database already within ChiroUp, it's going to generate referrals compared to anything else that isn't even close. For many of the practices I work with, this is their number one growth lever. It's just good doctoring. Actually, I stole that phrase from Brad Russell, a subscriber we have way down south here in the States. He said, just having good, clear communication with that referral doctor. Now, the second step that I think some people have to step out of their comfort zone a little bit, but I would highly recommend it, is a follow-up phone call to that referring provider, whether it's a dentist or a medical doctor, and let them know, hey, I evaluated your patient. Here's what I'm seeing clinically. Here's what I'm going to do to the patient. Because if you need something from them, like in a dentist situation, I need some kind of pain reliever, I need some kind of steroid, I need splint therapy, whatever it may be, whatever falls into their standard of care, you may need some help when it comes to the joint-related types of TMD. So something that just to consider, having a friend on the other end of the healthcare arena is going to significantly help. So that is the CRPT test. That is something that I would highly recommend watching the video in ChiroUp and doing on every single patient that comes in to see you for jaw pain. Let's get into manual therapy though, because there's two things that I want to focus on, the masseter and the superior lateral pterygoid. When it comes to manual therapy, for TMD, this is something that we must consider because the superior lateral pterygoid is the muscle that plays really a critical role in TMJ health because of what it does. As we've already discussed, the TMJ is that ganglionoarthroidal joint, meaning it does go through rotation and translation. So if you thought we were going to miss that later on in the podcast, we're going to drop right back into it because this complex motion frequently becomes dysfunctional. And here's why. So the superior lateral pterygoid, about half the muscle attaches directly to the disc and the other half attaches to bone, which means that activation of this muscle, when it's hypertonic, when it's not used properly, when you have too many issues with this muscle, it can actively control disc position when you're going through mouth opening. And when you have dysfunction, the disc and then ultimately the joint is going to pay the price. So this is where you see popping, clicking, cracking, grinding, all the things that we have with this slip disc during jaw opening are dysfunctional disc. I shouldn't say slip disc. Those sounds are not random. They're influenced by this disposition, and ultimately that muscle function. So clinically, one of my first steps is to assess the tone of that muscle. Now, depending on your state, your limitation, your training, at least in Illinois, I can go intraoral. So with my finger, I'm going right along the teeth on the top part of your mouth, and I'm feeling the separation between that mandibular condyle and those teeth. Now, be careful with your older people when they don't have their teeth. You want to make sure you address that also. However, what you can do is see how much play you have in that mandible. A lot of times it'll be stuck there. You can tell that muscle, that superior pterygoid, is holding that mandible really tight, which is of course going to be affecting that jaw motion. If you want to check out how to release it in ChiroUp, STM of the superior lateral pterygoid, you're going to be sticking your finger back there and providing a little, we'll say a little distraction of the joint. And through proper head motion and keeping constant pressure on that mandibular condyle, you can release that muscle. It usually takes 20 to 30 seconds. In all honesty, it's not the most comfortable for the patient, but after that muscle releases, you'll feel it kind of twitch and quiver and then slowly release. The patient's going to feel wonderful after that. The next muscle that we're going to do, and I do more of a contract relax muscle or stretch for this muscle, is the masseter. Another intraoral approach. However, this soft tissue manipulation of the masseter through contract relax really works well. And what you can do is having your thumb on their lower incisors, using your a nice firm pressure. Make sure you don't grab their lips. That doesn't feel very comfortable. And then the rest of your hand is holding the chin to control mandibular motion into gentle depression and retrusion. So what they're going to do is, while you're holding their mandible and you hold the top part of their head, they're going to give you about 10% of their effort attempting to elevate the mandible into your finger. So biting up in your thumb. Now, the key is don't let them move their upper teeth, because then you will quickly lose your thumb. However, only let them push up with the lower mandible, and they're going to hold that isometric contraction for about 10 seconds. After the contraction, cue the patient to just relax. Now, it hurts. The jaw hurts. They don't really want to relax. It's kind of like the shoulder. It's an unstable joint. So what I will do is, when they relax, I'm going to try to increase mandibular opening and inferior glide. And if it is uncomfortable, or if the patient is unable to relax, have them yawn. Yawning activates the jaw depressors, it inhibits the elevators, and it helps move past the protective muscle tone without really forcing that motion. It's kind of an elegant way to let neurology do some of the work for you. And this is a great way to help improve jaw range of motion, because what we find is that patients with TMD, to get into that diagnosis, one of the key variables is jaw depression does not go past 40 millimeters. So you can do this with a Therabyte. Makes a great ruler that you can measure this. That's a throwaway ruler, so you don't need to wash it or anything. However, improving jaw range of motion is going to be critical. So those are two great techniques. If you go into treatment techniques in ChiroUp, you'll be able to access those videos. And then, how can we tie all those things into rehab? Because my job is to get things loose. The patient's job is to keep things loose so we can let things heal. Now, when it comes to rehab, I have a couple exercises that I've built into to my protocol. So when I do my note for TMD, it takes about a minute to do the initial note. It takes about 13 seconds to prescribe the rehabilitation exercise and condition report. However, I need to make sure that I relay all the information that I know about this condition. And I want to cover two of those things in this section of the podcast. The first is going to be a rehab exercise. The second is going to be some real life ADL information that's going to help this patient get out of their problem. So first, let's start with the rehab. So the jaw depression exercise is easily my favorite starting point. Now, I often pair this with a cervical retraction exercise for any kind of upper quarter postural or pain syndromes. However, for the actual jaw, this exercise, the reason I use it is simple. It teaches the patient how to open the jaw correctly. It teaches them how to open the jaw without excessive translation with that first 50% opening. Now, you may think this is crazy, but when you watch people open, they go straight for that double cheeseburger instead of that single cheeseburger. They never go through rotation. And there's a lot of etiological answers for this. And if you dive into the condition reference section for temporomandibular disorder, you're going to go through the etiology section and you can see all those things. I don't have time to cover it right now. However, here's how I'm actually going to fix that problem with that exercise. So the jaw depression exercise, here's how I coach it. Here's why it's important. What you're going to have your patient do is place the tongue, their tongue, not your tongue, their tongue on the roof of their mouth. And they're going to say the letter N. So if you do that right now and you say letter N, your tip of your tongue goes to the back of your incisors. Keep your tongue there and then slowly open your mouth as far as you comfortably can while avoiding popping, clicking, cracking, or pain. What this is going to do is that tongue acts as a natural block. It prevents early anterior translation and allows only pure rotation during that initial half of motion. So it can create this slow, controlled motion and hopefully pain-free, and it is essentially retraining their nervous system and retraining their brain that they can open their mouth without symptoms, and that confidence matters. I typically prescribe this exercise once an hour, and I do it for about 10 controlled repetitions, and during the first maybe 1 to 2 weeks of care, it's safe, it's effective, it works really well. And the most important part is you will have a blast watching patients try to do this for the first time. It's actually quite hard. Not that we want to have a laugh at our patients' expense. However, it's always fun to watch patients try to do this exercise. Just laugh when they leave the room, not while they're in the room. The clinical pearl on this is that you are not doing something they can't and forcing it. You are teaching the joint it is safe to move again, just as we do in every other joint or condition we treat in the body. Now, I said that was only half the battle, and I truly 100% believe that. Because the second piece of this is actually the behavioral care of what we do. Now, I have that in my condition report. So I need to have a couple cues, couple things to talk to them about, because really in conservative care, education plus habit reversal is going to solve the problem. You and I understand there is no TMD fairy. No secret magical thing happened to this patient to create this problem. They did it to themselves. Besides like a dental procedure or trauma, which does happen, the vast majority of these cases are due to what the patient did to themselves. So a couple things. First, try to keep their lips together and teeth apart all the time. So that's just something I tell my patients, that if your lips are together, you're breathing through your nose, you're not a mouth breather. There's a lot of research on that, which is good. But teeth apart is a second piece of that to avoid bruxism and to let that masseter relax a little bit. The second is daytime clenching, which is that teeth apart mentality, just having it posted on their computer screen to make sure they're not doing that. And the last one being sleep hygiene, getting the proper amount of sleep. Once again, that is a whole nother podcast. Keeping the screen down, get to bed, get some sleep. It's going to help a lot with these chronic, overlapping, multifactorial diagnoses that we see all the time. All right, before we wrap up today's episode, we want to share something special with you. Right now, this podcast is sitting at about 70 written reviews between Apple and Spotify, and I'd love to get that to 100. Those reviews make a huge difference in helping more chiropractors find the show and keep the conversations going. So, to say thank you, from now until March 25th, 2026, we're doing a giveaway. All you have to do is enter a written review on Apple Podcasts or Spotify during that time. When the entry period closes, our marketing team is going to randomly select 3 winners, each winner getting a $50 gift card from Amazon. If you're selected, we're going to reach out to you directly, coordinate the details, and get your permission to give you a shout out in the next podcast. Most importantly, thank you for being part of this community and for listening. Because of you, we're able to connect with chiropractors around the world and continue to bring the research and the conversations that's going to help the profession move forward. Thank you. Now, to close things out, I want to leave you with one business practice advice, is I guess what I'm going to call it. This is one reporting habit that has really outsized its impact on our practice since the inception of the EHR. And the reason I say that is because from day one, we make sure that 2 reports are run every single day. And I believe these are absolutely critical, at least for our practice. I'm sure maybe once I say this will be important for your practice, because now that we have about 500 chiropractors and about 1,000 people running the software every single month as far as the EHR, and several thousand running the patient education wing of our software. This, as far as the EHR, is one of the most widely, I guess maybe is a better word, used reports across our subscriber base. So inside the billing tab, inside the ledger report, there are 2 things that you really must have discipline in. Is that every morning my staff runs a report from the previous day to confirm that every visit has insurance attached and every visit has service codes attached. This is one step to ensure that yesterday is cleaned up, meaning claims are created, claims are sent, and nothing slips through the cracks. Because at the end of the day, we don't want your work, your good work, not being compensated. So if your claims are going out the door, that's a really good thing, because we need that money coming back in, making sure that every patient you see has the insurance attached and that codes are attached. Make sure that everyone in your clinic did their job, and then let the software do the rest of automatically bringing that money back in. This habit alone keeps my business healthy. It keeps it predictable and keeps it out of the red. Thanks for listening to the podcast. This is one of my favorite diagnoses, TMD. I think that incorporating the CRPT tests can help differentiate if they are a good fit for my practice. Doing the manual therapies that I talked about, and then also incorporating the rehab exercise and some patient education will help you and your patients get out of this problem quickly. As always, if you like this kind of episode, send me an email, brandon@chirop.com. This one was my own little side project podcast. However, the last 3 have all been feedback or suggestions by subscribers. So I love to hear the feedback. I constantly I'm looking for ways to help chiropractors answer the questions they have in their practice, whether it's clinical or business. Otherwise, leave us a review for the podcast. Thanks a lot for listening.